So just a quick overview again for the circle of Willis. Our anterior circulation is fed by our internal carotid arteries on each side. Posterior circulation is fed by our vertebral arteries on both sides. So those are our two inflow channels. That's the two main pathways for blood flow getting to the brain, our internal carotid arteries and our vertebral arteries. Our internal carotid arteries come up and enter the carotid siphon where it does a loop. And then we have a branch where the internal carotid artery branches into our middle cerebral artery and our anterior cerebral artery. So this is usually where we begin our transcranial Dopplers. We try and find this landmark, which is designated by this bidirectional flow, where we have the middle cerebral artery flow coming towards us and the anterior cerebral artery flow going away from us. As we get down a little bit further, you'll notice we'll see a hypoechoic butterfly in this region of this area, and you'll be able to recognize that. So our vertebral arteries, we're coming from our suboccipital window, and blood flow is going to be away from us in both the vertebral and the basilar arteries. So here's an example of that Cca Aca bifurcation. So you have your waveform of your MCA, your middle cerebral artery above the baseline because it's coming towards you, and your anterior cerebral artery below the baseline. Velocities will be higher in your middle cerebral artery and lower in your anterior cerebral artery. This is the posterior cerebral artery from the transtemporal window, with the blood flow coming towards you. Visualize the transducer. So here's your basilar artery coming up, and your posterior cerebral artery with blood flow coming towards you. So this is the P1 segment. If I was to image a little more lateral in the P2 segment, if I kind of angle my transducer in that direction, blood flow would then be trailing away from me. So in the P2 segment, you get below the baseline. So P1 towards the transducer, P2 is going to be away from the transducer. A lot of this is going to make a lot more sense in the fall when you go to the TCD lab with Mary Jo. She's very good. I was actually speaking with her earlier in the week, and we were coming up with your fall schedule where you come in to do the transcranial Doppler. So you guys will be going in groups of 4 and actually scanning on each other. She'll check all of you to make sure you have proper windows, and you're going to be learning and actually doing an official printout where you'll be able, well, you'll submit to me with your transcranial Doppler measurements, imaging all these vessels. So with our transorbital approach, we image the ophthalmic artery with blood flow coming towards you, as well as you can visualize the anterior cerebral arteries. And you can also image the carotid siphon as well. So I think we left off on getting into like vasospasm. So this was actually an important point. Increasing concentrations of CO2 in the blood will dilate vessels and increase flow and velocities. So this is important when there's a stenosis or a blockage in one of the cerebral vessels. Doctors will actually do a treatment where they create hypoxia in the patients and try and increase CO2 levels in the blood as a means of dilating the vessels and increasing blood flow to stenotic lesions or ischemic sections of the brain. So increasing CO2 levels in the blood dilates the vessels, increases flow, as well as increasing velocities. So I think this is where we left off. So in transcranial Doppler, there's an index called the Hemispheric Index or Lindenbroad Index. So this index is similar to our carotid ratio that we have when we're doing the extracranial carotid arteries. So this ratio involves the middle cerebral artery velocity divided by the Ica velocity. So this velocity, just as with our carotid velocity ratio, it's designed to show a level of increase or how fast is the blood flow accelerating from one point to another. So this velocity will help to distinguish between vasospasm and states of systemic hyperemia, or states where we have a global increase in the velocity of blood flow. So in states where you have systemic hyperdynamic states, both the middle cerebral velocity and the internal carotid velocities will be increased, thus there'll be no change to that ratio. So if this goes up by a factor of 3, this is going to go up by a factor of 3. So that ratio maintains the same. In cases where we have vasospasm, we'll have an increased velocity in that middle cerebral artery compared to that internal carotid artery. So if we have a hemispheric index of greater than 3, that'll indicate pathology or the presence of vasospasm. So if we remember, vasospasms are a common occurrence or a critical occurrence that can happen in patients that are post-subarachnoid hemorrhage or brain bleed. So like these are patients that have any sort of brain trauma, intracranial hemorrhage from a hemorrhagic stroke, brain bleed. So that vasospasm is going to cause pressure on those vessels and will essentially create a narrowing of those vessels, which can mimic a stenosis. So the protocol at Christiana Hospital. So this is the protocol for transcranial Doppler. So they measure the middle cerebral artery, that Cca Aca bifurcation, anterior cerebral artery, posterior cerebral artery, terminal Ica, as well as the communicating arteries. Transorbital window, they're doing the ophthalmic artery and the carotid siphon. Transforaminal or the suboccipital window is going to be our vertebral arteries and basilar artery. And submandibular is going to be that distal Ica. So intracranial stenosis and occlusion. So stenosis, we know stenosis is we see an increased flow velocity. So we have increased velocities at a stenosis, as well as just disturbed flow or turbulent flow. And that turbulent flow is, we know, is demonstrated by spectral broadening. We can also have something called a co-vibration phenomena. So we'll see that a little bit further down in our slides. Some conditions are hard to distinguish from stenosis. So some of these conditions could be if there's potentially collateral flow in the intracranial arteries. intracranial arteries supplying an AVM or an arterial venous malformation. And it's also hard to distinguish a true stenosis from a vasospasm. So again, if we remember the primary causes of arterial stenosis, it's going to be our atherosclerotic plaque, as well as emboli. So occlusion. Occlusion is defined as the absence of arterial signal at an expected depth range. So presence of signals in vessels that communicate with occluded arteries. Altered flow in communicating vessels. So if we see altered flow in some of these communicating vessels, it could indicate collateralization, which could mean that there's the presence of occlusion. So if we have a potentially occluded vessel, we could basically prove that by demonstrating flow in communicating vessels, as well as flow direction. If we have retrograde in a particular vessel, it could indicate that we have collateralization, thus indicating the presence of a possible occlusion. So this is a chart showing our mean flow velocity thresholds for transcranial stenosis. So this chart will be posted in pretty much any vascular lab where you're doing transcranial Dopplers. This is similar to that carotid velocity ratio chart that you'll see. So we can see that this chart for transcranial Doppler, our stenoses are broken down into greater than 50%, or greater than 70%, greater or equal to 70% stenosis. So for our middle cerebral artery, we look for velocities over 100 to indicate a stenosis. Anterior cerebral artery, again, we use that value of 100. For our ICA siphon is greater than 70. Posterior cerebral artery is going to be greater than 50. For our basilar and vertebral arteries, they're going to be 60 and 50 respectively. The nice part is when we're doing our criteria, we do greater than 100 and greater than 80, greater than 128 and greater than 119. So this is an example of a middle cerebral artery stenosis. So this is a normal proximal flow. Then as we approach the stenosis, or we get into the stenosis, we have increased systolic and diastolic velocities. We see our spectral broadening. And we get distal turbulent flow. Distal to the stenosis. So this is another example of a left MCA stenosis. We get a mean velocity of 171. Go back to our chart. 171 will fall into our greater than 70% stenosis. I forgot to mention, so going back to this chart, we also will use a ratio as well to show the increase in the velocity across the segment as well. So these ratios of 2:1, or 1:2 and 1:4, we also use in our grading criteria as well. So this is an example of two segments in the middle cerebral artery, where our M1 segment has a normal velocity, but our M2 segment is elevated at 182. So using that systolic ratio of 2.8, this will indicate a stenosis of greater than 50%. So also we need to remember that the percent of stenosis is a measurement of diameter reduction. So DSA is digital subtraction angiography. And MVF is mean flow velocity. And the SPR is the stenotic to pre-stenotic ratio. So our machines are going to calculate our ratios for us. So some of the things that we're looking for is going to be increased pulsatility. So proximal to stenosis or occlusion, we have increased intracranial pressure. So the image on the right showed a basilar artery proximal to stenosis. So this is a good example of how pre-stenotic we have a high resistant waveform. So that blockage or stenosis is creating increased pressure upstream, which is going to result in us showing a high resistant waveform proximal to that stenosis. So a distal stenotic lesion will create a more proximal, high resistant waveform. So this isn't a normal cerebral arterial waveform. So we know that our cerebral waveforms should be like our internal carotid artery, nice and low resistant with a large diastolic flow component. So some potential pitfalls could be lack of flow signal due to inadequate acoustic windows, misrepresentation of hyperdynamic collateral channels and arterial and venous malformation feeders at stenosis or as stenosis, displacement of the arteries because of a space occupying lesion. So if the patient has a brain mass, or if they have a large internal hemorrhage that's displacing the vessels, we could potentially be imaging the wrong vessel. There could be misrepresentation of that vessel because of that space occupying lesion. Misrepresentation of physiologic variables in the circle of Willis. We could have misdiagnosis of vasospasm as a stenosis, or misrepresentation of hyperemia following spontaneous recanalization of stenosis. So if we have a stenosis that all of a sudden recanalizes, that area of the brain that was ischemic is now going to demonstrate hyperemia or increased blood flow, because the brain's going to all of a sudden try and get blood flow back to that area of tissue that was ischemic for that portion of time. So that's going to increase velocities and create a false sense of area of stenosis. So this is particularly true when we're doing our transcranial Dopplers and we don't have the image portion of that with it. So when we get into our TCCS imaging, it allows us to be more accurate in terms of visualizing the vessels and interpreting, that we're on the correct vessel. And it helps to aid in the misdiagnosis of vasospasm versus stenosis. Pitfalls, difficulties with vertebral artery and basilar artery diagnoses. So normal flow and size of the vessel are highly variable. So you saw that when we were here in the lab scanning people's vertebral arteries. Some people had nice large vertebral arteries. Other people have very small vertebral arteries. So the size and normal flow volumes within the vertebral arteries can be variable. The location and course of the arteries are unpredictable. And often the junction of the vertebral arteries cannot be reliably identified. So the vertebral and the basilar arteries are essentially flowing, in that same direction away from us. So without the help of, our 2D and color picture, we're just going based off of sound. And it's really tough to really pinpoint, where exactly that junction of the vertebral arteries is. I mean, we have a general idea based on depth, but we can't be 100% certain. So absence of a vertebral artery flow signal on one side may not represent disease. Occlusion of one vertebral artery or a top of the basilar artery occlusion does not necessarily lead to relevant flow abnormalities. So now we get into our transcranial color-coded duplex sonography, or TCCS. So this is a diagnostic method allowing non-invasive imaging of the intracranial vascular structures. It combines B-mode sonography with frequency-based color coding and Doppler sonography. So it provides more rapid and reliable vessel identification, reveals vascular and parenchymal anatomy, detects a wide variety of cerebral vascular pathologies, and it's good for monitoring intracranial artery stenosis and confirm arterial occlusion diagnosis. So with transcranial color Doppler imaging guidelines, we want to take a patient history, focus on history, risk factors, and symptoms. We also want to be aware of the status of the extracranial vessels. So we want to know what their values are for the ICA and CCA. We want to know if there's any abnormalities. We want to know if there's a subclavian steal prior to doing our transcranial color Doppler imaging. Because if the patient has internal carotid disease proximally, it's going to affect what we expect to see in our transcranial color-coded Doppler imaging. Understand how each color control affects the image and how the controls affect each other. Use the color power Doppler display as a guide to obtain the Doppler spectral waveform information. Use a large Doppler sample volume. So we're going to have our sample gate at 10 to 15 millimeters. And assume a 0-degree angle. Be aware of Doppler spectral waveform configuration. Compare the Doppler spectral waveforms from the anterior and posterior circulations and from the right and left sides. So we're comparing our right and left as well as our anterior and posterior circulations. Because remember, if we have an issue in the posterior circulation, we can have compensatory from the anterior circulation, or we can have compensatory from the contralateral side. And we want to establish institutional diagnostic criteria for the various clinical applications. So the TCCS examination, we go through the transtemporal and suboccipital approaches. So for the transtemporal intonation approach, we're going to look for this hypoechoic butterfly-shaped midbrain, and it's visualized as an anatomical landmark at a depth of about 60 to 80 millimeters. For the suboccipital intonation approach, we're going to look for a hypoechoic foramen magnum and the hyperechoic clivus, and these serve as anatomical landmarks. So here you can see this arrow here is pointing to that hypoechoic butterfly. That's going to be our anatomical landmark for our transtemporal approach. So if we kind of visualize our transducers here on the patient's temple, and we're scanning from lateral to medial. So transducer here. So we have our middle cerebral artery coming towards us, towards the transducer. This is going to be the middle cerebral artery on the other side. A posterior communicating artery. Say this is the patient's right. We'll just say this is the patient's right. And the posterior cerebral artery on the other side. Anterior cerebral artery. Both sides. So the posterior cerebral artery can be visualized as they flow to the edge of the midbrain. With excellent bone intonation conditions, the entire circle of Willis can be displayed. This is a good example showing that hypoechoic butterfly that you're going to use as your landmark. And our middle cerebral artery coming towards us, anterior cerebral arteries, posterior cerebral arteries. So in this image, not all the vessels of the circles of Willis are visualized. And transtemporal approach. Transducers on the patient temporal, our middle cerebral artery going towards us, a posterior cerebral artery. So this is a good example of the P1 segment and P2 segments. So P1 coming towards us, P2 segment is in blue going away from us. Anterior cerebral artery in blue going away from the transducer. And then our other window is going to be our suboccipital window to visualize the vertebral arteries and the basilar artery. So flow direction is going to be away from the transducer. So if we try and visualize the transducers here on the back of the head, and our flow direction is going to be away from us, so our vertebral arteries. So we have our right and our left vertebral artery coming together, joining the basilar artery, and this is all flowing away from the transducer. So it's in blue. So you can see with the TCCS, when we're able to get a picture, we can now clearly visualize, that junction or that union of the vertebral arteries into the basilar artery. So here you can see that hypoechoic foramen magnum. It's here by the asterisk. That's going to be your landmark that you're using to try and image the vertebral arteries and the basilar artery. So visualization of the hypoechomic foramen magnum is marked by the asterisk and proves the adequacy of the ultrasound penetration. See, this is that hyperechoic clivus. So the origin of the basilar artery at a depth of 75 to 95 millimeters in most cases. And you should see the Y-shaped conjunction of the vertebral arteries with the basilar artery is usually close to that clivus. So detection of intracranial stenosis and occlusion with TCCS. Detection of intracranial stenoses of 50% or greater diameter reduction based on the table below show excellent accuracy. So occlusion diagnosis is based on absence of flow signal using both color and spectral Doppler modes. So that's important. If we really want to diagnose that a vessel is occluded, we need to demonstrate it both in color and spectral Doppler. And then the chart below. So this shows our velocity cutoffs. And if we have a peak systolic velocity greater than 220 for our middle cerebral artery, we have 100% sensitivity and specificity that we have a stenosis greater than 50%. So these, again, this chart will most likely be in a lab that's doing your TCCS for your values of 220, 155 for your anterior cerebral artery. Just remember that your posterior circulation velocities are always going to be less than your anterior circulation velocities. So if we go back up to that other chart with our transcranial Doppler, you'll notice that as well. Your posterior circulation velocities are always going to be less than your anterior circulation velocities. So posterior circulation, we have 80 and 119. Anterior circulation is going to be essentially 190 and 128. So this is through the transtemporal window. We have a pre-stenotic flow in the middle cerebral artery. This is your velocity pre-stenosis. At the stenosis, we get velocities of over 300. This is an example of a middle cerebral artery occlusion and recanalization. So proximal MCA occlusion with contrast enhanced TCCS in an acute stroke patient. Then several days later, we had spontaneous MCA recanalization. And now the entire MCA is depicted with contrast enhanced TCCS. So with basilar artery stenosis in a stroke patient with the anterior circulation symptoms, an asymptomatic basilar arterial stenosis and subclavian steel phenomenon was demonstrated. sickle cell. So sickle cell anemia, we know this is an inherited disease caused by a defect in the gene that codes hemoglobin. The erythrocyte appears sickle and shaped and are fragile. The reason this is important for us in vascular is they can adhere to the blood vessel, producing a blockage. So patients with sickle cell, when they have a sickle cell crisis, they're often in extreme pain. They'll have swelling of the extremities, decreased immune function. They're more susceptible to developing gallstones, kidney failure, but they're also more prone to stroke. So this is an example of a patient with sickle cell anemia. This was an 8-year-old patient with sickle cell disease that had a stenosis in her middle cerebral artery with velocities over 200. And the corresponding MRA showed intracranial arterial narrowing. These velocities are probably 300, really were to measure. So then we can also have potentially in the brain arterial venous malformation and fistula. So arteries which exclusively or partially feed AVM can be identified with increased velocity, reduced pulsatility, and reduced responsiveness to carbon dioxide. So an AVM or arteriovenous malformation, these essentially are fistulas or connections between our arterial and venous system. So this can be as a result of trauma or surgery, where we have now a connection between the arterial and venous system, or it can be a congenital defect where a patient is born with an arterial venous malformation. So with an AVM, we now have a connection, between the arterial and venous system. So these allow for, with our TCCS, these allow for localization of an arteriovenous malformation and its hemodynamic state. So the draining veins can be identified by pulsatile flow. So just as we were imaging our arteriovenous fistulas, we know that the draining vein or the venous portion of the fistula now has arterialized blood flow. So now we have pulsatile flow. So because we have arterial blood flow entering into a venous system. So those venous drains will have increased flow, which is now pulsatile. And now that there's arterial flow or arterial blood entering that venous flow into those venous drains, we now have a complete lack of flow response to Valsalva. So we lose that Valsalva response that we typically have when we're in a normal vein that's just venous flow. AVF is detected by very high flow velocities and severe flow disturbances at the site, or by arterialized flow in the veins that drains the fistula. So monitoring. We're able to do monitoring in cases of patients that are at risk for vasospasm. So in the ICU, we can hook up this monitor, which stays on the patient permanently and does continuity monitoring of our middle cerebral vessels. This monitoring can be done intraoperatively or in the intensive care unit. So these are patients that have had, some sort of brain trauma, that have subarachnoid hemorrhage or subdural hemorrhage, subdural hematoma. Perhaps they've just had intracranial surgery to remove a brain lesion. They could be susceptible to developing vasospasm. So vasospasm is a common complication which may occur 4 to 14 days following a subarachnoid hemorrhage. So the subarachnoid space is an area between the brain and skull, which is normally filled with cerebrospinal fluid, which acts as a floating cushion to protect the brain. When blood is released into the subarachnoid space, it increases pressure on the brain, making the person confused and lethargic. And this is often caused by aneurysm or arteriovenous malformation or trauma. Allow non-invasive, so the TCD or TCCS monitoring for vasospasm. It allows for invasive monitoring to study blood flow velocities in the basilar arteries, providing valuable information in the basal arteries, providing valuable information in patients with subarachnoid hemorrhage before and after surgery. So it can be used in triple H therapy, hypertensive, hypervolumic, and hyperdilution. So with this triple H therapy, what that means is hypertensive is we want to maintain a patient's blood pressure at a high enough level in order to ensure perfusion of the tissue of the brain. So some patients will actually increase or maintain a hypertensive state in order to maintain an adequate perfusion of blood flow to the brain. Hypervolumic, we want to increase blood flow volume getting to the brain in areas of infarct to prevent areas of infarct. And hemodilution. So we also want to dilute the blood in order to allow for more perfusion of the brain tissue. So we'll get into this a little bit more, particularly with the hypervolumic to increase the blood flow volume. That's going to be our CO2 therapy, where we're increasing the patient's CO2 blood CO2 levels. So TCD and TCCS monitoring for vasospasm. So intracranial Doppler can detect increase in velocity before the onset of symptoms, hours to days. So that's good. So if we're able to get ahead of the game in patients that are at risk for vasospasm before the onset of symptoms, we can start employing some of these therapies to prevent ischemic damage as a result of vasospasm. So it would allow early diagnosis of cerebral vasospasm and early detection of those patients that are at risk to develop cerebral ischemia, as well as monitoring the benefits of the available therapy as prophylactic treatment. And with TCCS, we may directly visualize the aneurysm in the brain. With TCD and TCCS monitoring of vasospasm. So the diagnosis of vasospasm is most accurate in the middle cerebral artery. Normal middle cerebral velocities are going to be less than 120 with a hemispheric ratio less than 3. So balloon angioplasty is the most common endovascular therapy in the treatment of middle cerebral of cerebral vasospasm. So they're actually going to go in there and try and balloon open that vessel to prevent an ischemic injury to the brain. So this is a picture of for vasospasm of our vessels for our middle cerebral artery on the right and the left. Oh, sorry. So we have our middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. So if we look at our velocities over here, you can see we're getting velocity of 358 and 242. If we compare that to the left side, we have 60. Well, I'm sorry. I apologize. The velocity of 156, 124. I'm sorry. So 156, 124. Velocity on this side is 72 and 70 and 42. So all posterior circulation isn't compromised. Our velocities are similar, waveforms look similar, but you see, increased velocities with turbulent flow. So this will indicate vasospasm of the right MCA and ACA. And the corresponding arteriogram demonstrates a vasospasm of the right MCA and ACA. So this is a printout of Tcd monitoring. So patients in the ICU, and we hook them up to that continuous Tcd monitor, which will monitor the patient's velocities. And then they're able to chart it out to see if it's progressing, getting worse. So here's another example of like the harness that they place. So we're able to do transtemporal, as well as transorbital. And this would be your transtemporal and transorbital monitor. I'm sorry, suboccipital monitor, transtemporal, and we can also place transorbital as well if needed. So you can see, they started monitoring on day 2, day 3. It wasn't until day 4 that we started exhibiting elevated velocities, and the velocity started coming down after day 9. So they're able to get ahead. Patient may have not been exhibiting symptoms at this point yet, so they could start with therapy and try and get those velocities back down and increase perfusion. So this is just a chart showing our average peak velocities or our mean velocities for our middle cerebral artery. And then if a patient would be at a moderate risk for vasospasm versus a severe vasospasm. And then this chart just shows our ratios. So this is that MCA to ICA ratio. And then our mean average velocities. So again, ratios over 3 demonstrate the presence of disease. Over 6 would be severe. This is just kind of grading the degree of vasospasm with velocities over 200, 150 to 199 for moderate, mild 120 to 149. And this is Christiana Care's criteria for grading vasospasm. This is what they use at the hospital. So this is peak mean velocities and suggested degree of vasospasm. Again, here our ratios are under 3 for normal and mild, and then for moderate, severe, moderate is 3 to 5.9, severe greater than 6, critical greater than 6. And then again, notice your anterior circulation velocities are going to be faster than your posterior circulation velocities. So intraoperative monitoring using transcranial Doppler. Again, this is a non-invasive and allows continuous or intermittent monitoring during surgery and can detect rapid changes in blood supply. That allows us to deliver direct and immediate information regarding cerebral perfusion and allow rapid modification of therapy. So examples of procedures where they could potentially do this would be during carotid endarterectomy, open heart surgery, and intensive care therapy. So in the intensive care unit, monitoring using transcranial Doppler, we affix the continuous monitoring by, we do continuous monitoring by fixing the probe at certain locations using the helmet-like device that we saw above. Monitoring can be used for subarachnoid hemorrhage with vasospasm. If the patient has increased intracranial pressure after a head injury. Monitoring if in cases of severe cerebrovascular occlusive disease or cervical artery dissection. On cases where there's high or low pressure hydrocephalus or swelling within the ventricles or low flow states associated with extracranial occlusive disease. So if we want to monitor flow within the brain, if the patient, say, had like an embolic stroke, if that's now blocking the proximal ICA and the extracranial ICA, or if they have severe occlusive disease in that proximal ICA and they have low flow getting to the brain, to monitor. Patients that have very low ejection fractions, myocardial failure, or valvular disease. And we can also monitor impending brain death. So this is a patient that had a cerebral aneurysm that was treated with a coil treatment. So a coil treatment, they're basically going in and using a heated coil to embolize the artery to close off the part that's bleeding, seal the part that's bleeding. So this is post-coil day 4. So your middle cerebral arteries, they're slightly elevated, not terrible, but you have severe high elevation of the right basilar artery at 219. So they performed angioplasty to dilate the arteries with the critical spasm. So they dilated that basilar artery. Then post angioplasty, they had basilar artery velocities, mean velocities of 69. Oop. So then this is showing post angioplasty. So this was pre and then post angioplasty. So this is a picture, grayscale color with power, angio of a left MCA stent. So we can also use transcranial Doppler in detecting microembolic signals or EMS. They're also called high intensity transient signal or HITS. So detection of microembolic signals. So transcranial Doppler allows one to non-invasively detect and quantify microemboli circulating through the cerebral arteries. A microembolic TCD signal must be random in occurrence during the cardiac cycle, be short in duration, so it's less than 30 milliseconds, have a very high intensity, at least 3 decibels above the background signal. They're mainly unidirectional within the Doppler spectrum. And if we're listening to them, they'll have an audible component and produce a characteristic sound that sound like a sharp chirp or a snap or a moan. Permit it. So this TCD permits the assessment of the actual thrombolytic risk and permits for monitoring of treatment efficiency. Effectiveness. Effective. Why would you write that? Effectiveness. So it permits for monitoring of treatment effectiveness.
Efficacy?
Efficacy. I can't even. Yeah, it's effectiveness. How effective is your treatment? So this is what those microembolic signals are going to look like. They're going to be these very bright, intense echogenic like dashes or stripes. You'll see them here too. Here, this is another microembolic signal. So it's going to appear like a very intense aliasing within your spectral waveform. And they're going to be just random. So these MES appear randomly in the systolic and diastolic phases of the Doppler. The origin and maximum intensity evaluations are always located within the Doppler spectrum. So this is the criteria for counting embolic signals. So the different criteria. So they got to be transient, lasting less than 0.3 seconds. They have to be a high intensity. They're typically unidirectional, so within the same direction of the blood flow. So you're not going to typically find these below the baseline. And then they're accompanied by that audible sound. So power M mode Doppler shows the track of emboli in time and space and provides simultaneous real-time assessment of emboli passing through different vessels, thereby increasing the yield of emboli detection with a single transducer. So using the power Doppler mode, we're now able to visualize those microemboli. So this is the MES and the MCA and ACA on power motion mode Doppler. This is the M mode, the motion mode. And this is also represented on our spectral tracing. So the power M mode actually was able to pick up some of those microemboli over here, whereas our spectral tracing, we didn't pick those up. We picked those guys up here, picked that one up here, picked this guy up over here, but these guys we actually missed on just the spectral tracing. So this power M mode is more sensitive for picking up those microemboli, and we can get a better idea of just how much emboli is traveling through a vessel. So this is an artery to artery embolus. So power motion transcranial Doppler shown on left. The spike on top of tracing and change in velocity at the bottom of the tracing. On the right, the typical diffusion weighted brain imaging shows scattered embolic strokes. So we can also use this in the detection of PFO. So we know in our cardiac that our PFO is a right to left shunt in the heart. And we can also evaluate it using transcranial Doppler. So the patients wear special headgear to allow bilateral Cca monitoring. So contrast agent is administered. That's going to be our agitated saline, our saline bubbles. It's injected into a vein in the arm during resting state to detect any microemboli. And then we ask the patient to Valsalva. And then using transcranial Doppler, we can actually image the microbubbles traveling. When they Valsalva, the microbubbles travel through the PFO into our systemic circulation. And then thus, goes into the left side of the heart. And then eventually that circulation winds up into the brain. So we're able to, using our transcranial Doppler, image those vessels of the brain, the middle cerebral artery. And we can detect the presence of those microbubbles now in the cerebral arteries. So if the patient does not have a PFO, that agitated saline that we've injected into the brain, it's just going to go to the lungs and get uptake by the lungs. So we're not going to demonstrate any microbubbles in the arterial circulation. But if there is a PFO, when we have in Valsalva, those bubbles cross over, the intraarterial septum through the PFO into our systemic and arterial circulation, which then goes to the brain. So in our transcranial Doppler, we're able to detect those microbubbles in the presence of a PFO. So Pfo grading is based on the number of hits or the number of spikes recorded following contrast injection. So based on this in the international consensus scale, to determine that even one hit is consistent with a PFO. So if their patient has even a minor or small PFO, we'll get one hit. If there's no hits, then there's no PFO. But even one hit constitutes a PFO. So again, those arrows indicate those microbubbles or the microemboli. In this case, we've created those emboli through that agitated saline, those little saline bubbles. So the arrows point to emboli in the waveform of the MCA after injected of agitated saline, and a patient tested for patent foramen ovale. So this would be that M mode color Doppler. So this would be a positive bubble test for a right to left shunt. With the patient Valsalving, we get a whole bunch of hits. So this would be a very large PFO. Again, this shows multiple hits. This is a patient with a large functional foramen ovale. The Valsalvum induced curtain of embolic signal in the MCA indicating the presence of a large functional shunt. When we have the Valsalva, get a large crossover of those microbubbles. So this is just a chart that we found that grades the PFO based on the number of hits. So cerebral venous thrombosis and intracerebral hemorrhage. So cerebral venous thrombosis can be diagnosed using our TCCS. Some of the sonographic criteria are abnormal elevation of blood flow velocities within the intracranial sinuses and veins, and also direct visualization of sinuses with decreased or absent flow. So that's one of the benefits of our color-coded sonography, is we actually can visualize these venous sinuses and veins And we can potentially visualize the thrombus or absence of flow within those vessels. We can also use our transcranial Doppler to determine brain death. So that's another test or function for our transcranial Doppler. So brain death is based on critical criteria, as well as electroencephalographic criteria. So that's going to be our EEG monitoring or the electrical activity of the brain, as well as angiographic demonstration of absent intracranial circulation. We can demonstrate cerebral circulatory arrest, as well as reflex phenomenon during late systole. With brain death, we're looking for increased resistive indices. And all these factors must be used in conjunction with other clinical and other laboratory markers of brain death. So we can't just go based on, one test to determine brain death. We have to put it all together along with the patient's clinical factors and markers, laboratory markers. So this is just a example of our spectral tracing showing the progression of brain death. So our normal spectral tracing that we'd expect for an intracranial vessel is a nice low resistant waveform. And as brain death progresses, we get more and more, less and less diastolic flow and a higher resistive indice until we completely lose diastolic flow component. And we have just a systolic phase. We see becomes more and more or higher and higher resistant. As it progresses, we then wind up with that reflux phenomena. So we want to go from a biphasic to a triphasic to a triphasic with a reflux component. And then eventually no signal at all. Get diminishing of that systolic component. So then this is just that thumping that we'd recognize with our, our carotid scans to no signal. So this is our middle cerebral and CCA and brain death. So our middle cerebral artery, we visualize that reflux phenomena. And then this would be an example of a common carotid artery in a patient with brain death. So our brain, the vessel is occluded in the brain, so we don't have any diastolic component in our common carotid artery. So the left image shows an ICA oscillating or reverberatory flow is the hallmark of cerebral circulatory arrest. So this is in the patient's ICA now. So the brain essentially has arrested. So cerebral circulatory, the circulation in the brain has stopped. So we're getting blood flow going in and then it's just coming right back out because the brain isn't, it's not, there's no need for the blood flow. It's the blood flow circulation when the brain has essentially stopped. So assessment of effects of extracranial occlusive disease. So in patients that have extracranial occlusive disease, we would expect to see collateral flow patterns within the intracranial vessels. So some of the things that could cause it are carotid stenosis or occlusion. And then it's up to us to identify the collateral flow patterns. So with TCD and TCCS are used to identify these collateral flow patterns. So our four main collateral flow pathways can be distinguished. So we're going to have our collateral flow pathways via the anterior communicating arteries, via the posterior communicating arteries, via the ophthalmic artery from our branches that we have with our ECA and so that's our ECA ICA connection branches. So our branches at ECA will connect with the ophthalmic artery and provide a collateral pathway in patients with severe occlusive disease or severe stenosis of the extracranial ICAs, as well as via the ipsilateral leptomeningeal arteries. So this is just a chart showing some of the potential collateral pathways seen with extracranial arterial disease. So if we have a right ICA occlusion, we'll see retrograde flow in the same side or the ipsilateral anterior cerebral artery. So it's going to steal from that anterior cerebral artery to feed the middle cerebral artery in the ICA. So it'll come back down that ACA and feed into that carotid siphon and middle cerebral artery to feed the brain. And we'll see orthograde and increased flow in the contralateral ACA. And that collateral pathway is going to be through our anterior cerebral artery, anterior communicating artery. We'll see strong turbulence in the region of our anterior communicating artery. With our posterior communicating artery, we'll demonstrate direct visualization of the posterior communicating artery. We'll have increased velocities in the P1 segment on the same side. Our velocities ratio in the P1, P2 segments will be greater than 1.5. And increased velocities within the basilar artery as well. Within the ophthalmic artery, we can, if there's collateral flow, we can see retrograde flow on the ipsilateral ophthalmic artery. So this is a young man with a thrombolic occlusion of the right ICA. So here we're Dopplering. So we can see this is looks like a large fresh clot or thrombus within the patient's ICA. There's no blood flow getting through. The right MCA appeared normal, shown below on the left. And the left ICA also appears normal. But we get retrograde flow in the anterior cerebral artery. And the posterior communicating artery is visual. The P1 segment is hyperperfused. So over here. All right, so here we have, over here is the anterior cerebral artery, which is in red. So it's retrograde coming toward you. This anterior cerebral artery should normally be blue with flow coming away from you. We have retrograde flow in our anterior cerebral artery. We're able to visualize the posterior communicating artery. Demonstrates some aliasing with some turbulent flow. And we're see increased flow velocities in the P1 segment. So we have increased flow velocities in the posterior cerebral artery and flow through the posterior communicating artery into the middle cerebral artery. So this patient is compensating through flow through the posterior circulation as well as stealing from the anterior cerebral artery. So this is a middle-aged man presents with occlusion of right ICA. We see increased pulsatility of the middle cerebral artery. So this patient also has a distal occlusion of the MCA. So we have a high resistant waveform with increased pulsatility. So they also have retrograde flow in that anterior cerebral artery. So we'll also look for contralateral velocity increases. So here we have right MCA, the mean velocity of 66, left MCA, mean velocities of 32. And this patient had a left extracranial ICA occlusion. So this patient's left ICA was occluded, so that limited flow to the left middle cerebral artery. And as a compensation, the right middle cerebral artery demonstrated increased flow. So we look for asymmetric mean flow velocities and lower pulsatility. So lower pulsatility is also a way of saying lower resistance. So pulsatility and resistive indices, those terms, they're kind of interchangeable. I mean, I prefer to go with our resistive indices as opposed to pulsatility. Right. So this patient's showing lower resistant flow with increased velocities. So assessment of effects of extracranial occlusive disease. So for the vertebral basilar system, the subclavian steal mechanism, we have rapid flow changes caused by vertebral artery restriction that can be measured within the basilar artery. So if the contralateral feeding vertebral artery is also diseased, the basilar artery may become reduced or demonstrate to a flow or may be reversed. So this shows that if we have normal flow direction in one of the basilar arteries, but a steal syndrome in the other, we could still have, or we'll still have normal flow direction in that basilar artery. If we have disease now, so a latent steal flow in the contralateral vertebral artery is increased during the brachial hyperemia and is normal in the basilar artery. In a manifest steal, flow is in the stealing vertebral artery is continuous is continuously reversed. The basal artery may have no effect, alternating or flow reversal. So here we have a bidirectional stele. We'll have normal flow direction. Here we have permanent retrograde flow. We can potentially have normal still or bidirectional or reversed flow. So some limitations of transcranial Doppler we went over already. So operator experience, improper instrument control settings, absent of poor transtemporal windows. If a patient's had recent eye surgery, we can't do our transorbital approach. Patient may have anatomical variants. Patients may be unwilling to cooperate. There may be displacement of the arteries by intracranial masses or lesions. With TCD in particular, we may misidentify a vessel. There may be misinterpretation of collateral channels or vasospasm as a stenosis. So functional reserve testing. So functional reserve refers to how much the vessel is able to dilate. So TCD is an ideal functional test for detecting rapid changes in cerebral perfusion. So with changes in CO2 concentration, the relationship between the velocity and volume within a large vessel, within a large cerebral artery vessel is linear. So there's a direct correlation between CO2 concentrations and the velocity and flow volume within a large cerebral artery vessel. So intactness of vasomotor reserve implies that a drop in perfusion pressure can be counterbalanced by vasodilation of the cortical arterioles to maintain sufficient cortical blood supply. So if we go back to like our hemodynamics and our Bernoulli principle, after stenosis, we have decrease in pressure. So that decrease in perfusion pressure can lead to poor perfusion of the brain. So that can be counterbalanced by dilating the vessels or vasodilation and maintain sufficient cortical blood flow perfusion to the brain. So that vasomotor reserve can be exhausted, or we reach a limit. There's only a limit as to so much or how far these vessels are able to dilate. And if that vasomotor reserve is exhausted, resistant vessels of areas of the brain with low perfusion may already be maximally dilated. So there's a test called the functional reserve testing using transcranial Doppler. So we test to the maximum extent to which the vessels are able to be dilated. So they evaluate the reserve mechanism of cerebral vasculature by detecting rapid changes in cerebral perfusion under various stimuli, such as hypocapnia, hypercapnia, increased or decreased systemic arterial pressure, and hypoxia. So with this reserve functional testing, we're essentially testing the patient's reserve, like how much are we able to dilate those vessels and how much are they able to compensate. So we do put the patient in a supine position, resting comfortably, and a mask is put on to administer various concentrations of CO2. And we remember that the CO2 has a dilatory effect on the arterioles, causing the vessels to dilate. This is an old picture showing the mask administering CO2. And we're performing our transcranial Doppler. to monitor velocities and flow volumes through the vessel. So vasomotor reactivity during CO2 induced hypercapnia or hypocapnia. So you could see that there's a direct linear relation to the volume of CO2 administered and the vasomotor reactivity and the velocity percentages. So ultrasound perfusion imaging. So using ultrasound contrast agent to enhance B mode imaging and allow ultrasound-based measurements of tissue perfusion. So this is a kind of a newer function of ultrasound. So introduction of contrast agent via bolus tracking approach or refill kinetics. So we can actually visualize perfusion of blood flow using a contrast agent and be able to detect areas with malperfusion. So this is a 70-year-old patient with MCA infarct, and ultrasound perfusion studies were done following bolus injection of a contrast agent. So B was 2.5 hours after onset of symptoms. And then C was 180 hours after the onset of symptoms. And then now with the advent of 3D probes, doctors can actually use contrast and get a 3D representation of our intracranial vessels. So new non-invasive method to investigate intracranial aneurysms. Data can be processed by different investigators and yield excellent correlation with gold standard. So it may be possible to improve reproducibility and increase the objectivity of transcranial color-coded duplex sonography. Power-based 3D TCCS, ultrasound with contrast agents. Images were enhanced using Ecovist. So sonothrombolysis, this is actually also a new application that's being used now with ultrasound. I've actually used sonothrombolysis in my can't even talk this morning. Need my coffee. Peripheral vascular lab with Dr. Pellerito. In our peripheral vascular lab, we use a contrast agent which acts as a thrombolytic agent because that contrast, when it interacts with the ultrasound beams, creates a microcavitation. If you remember back to your physics, that's that energizing of tissue, and that microcavitation actually helps to break up microplaques within the small arteries of the vessels and increases perfusion, distal perfusion in the vessels. So we, in the peripheral vascular lab, we'd use it for the peripheral arteries of the leg, these small arteries of the leg. So we inject the contrast and we actually image the contrast coming down the leg. And we put the transducer over the area that we want to increase perfusion of. And we keep the transducer there as the contrast, works its way down the leg. The ultrasound will activate that contrast and create microcavitation and help to break up some of that plaque and increase perfusion. So ultrasound assisted thrombolysis or sonothrombolysis is the installation of thrombus alone or in the combination of fibrolytic agent to accelerate the thrombolytic process. So using frequencies from 2 kilohertz to 3 megahertz and intensities within the 3 milliwatts to the 8 watt range. So with sonothrombolysis, may increase the efficiency of our effectiveness of pure pharmacologic approach of thrombolysis in acute stroke and improve long-term outcome of stroke patients. So the use of echo contrast enhanced agents can enhance the effects and further through microbubble induced cavitation. Establishing sonothrombolysis as a therapeutic tool could revolutionize the treatment of acute stroke. So if you think about that, we're now can potentially use our ultrasound transducer to help break up intracranial thrombus and clot. I personally have never witnessed this, but I've seen it with the application for peripheral vasculature. So that's pretty exciting. So the risk of intracranial cerebral hemorrhage is currently under investigation. So this is acute thromboembolism of the MCA. And we show absent or minimal flow. Our high resistant flow proximal to MCA leading to a low resistant flow in the ACA. So thrombolysis and brain ischemia classification, and then residual flow signals and the names of the flow grades. Good, absent, minimal. This is an example of a blunted waveform, a dampened waveform. So blunted would be our tardus parvis waveform with our low velocity, but we now have a diastolic component, tardus parvis. Our stenotic waveform would be our high velocity, high diastolic component. Our normal example of what our normal waveform should look like. So this is monitoring for MCA recanalization during and after thrombolytic therapy. So we should get a gradual improvement. That's going from our occlusion to mildly reduce to a stenotic signal as the clot's starting to break up to a normal signal. So this is the posterior cerebral artery on the same side to a middle cerebral artery occlusion after administering of contrast, showing a blooming effect. Only short flashes of red are visible in the ipsilateral MCA and M1 segments. It's functionally occluded by Doppler waveform evaluation. And the left middle cerebral artery is normal. This is an example of the probe in the suboccipital position, angulated slightly upward. So with this, the probe is suboccipital. So blood flow should be away from the transducer, but here we're getting red, which is retrograde. Blood flow above the baseline. Basal artery flows retrograde with low pulsatility. This looks like a dampened tardus parvus waveform. And compared to the normal one on the right. So arterial recanalization. So the upper row. So this is the TPA bolus. So TPA is that clot buster that they'll administer for patients during the first hours of a stroke. And you can see our progression. So this is our M mode. So then this would be our Doppler tracing. And then get a slow return back to normal. All right. I promise you this TCD stuff is going to be a lot easier to understand once you get into the lab and you start scanning it and get a better appreciation of, the to and the fro, like which vessels run in which directions, and you actually got your hands on the probe. It becomes a lot easier. Any questions about anything? So just, I guess for next week, just think about which topics you might want to do for your research presentation. Let me know by next week. I'm going to start posting the quiz, so you can start working on that. So our first quiz is going to be, I believe, cerebrovascular. We'll do cerebrovascular for our first quiz.
Then a question for pathology, should it be just the parts that we already studied, like upper extremity, lower extremity, or it can be abdominal, let's say, the ones that we haven't touched yet?
If you want to do abdominal, I'm okay with that. If you want to research it.
Let's say,
yeah, if that strikes your fancy, sure. Why not? I mean, we're going to be learning in the fall anyway, so.
No, but it can be any pathology, right?
Yeah.
It can be cerebrovascular,
Yep.
right? Anything.
Yeah.
Okay.
Yeah. What were you thinking?
I wasn't sure, because it seems like we already, DVT, we studied DVT, we studied something, arterial occlusions, but I don't know if we should go over that again or touch something new that we haven't studied yet.
Okay. Up to you.
Okay.
All righty.
All right, then we'll see you Monday.
See you Monday. Have
a nice weekend.
Bye, guys.
Oh, remember to wear your eyewear. I sent out a message to the first year students, Jesus. DMS girls, in the clinical setting with any patient interaction, we still have to wear eyewear. So,
Okay.
okay. I know like when Kathy was going around to sites, that's one of the things she's checking too. So she may show up at your vascular sites. I'm going to be seeing you guys at the echo sites, but she may be coming around to your vascular sites. So if she pops up, make sure you have your eyewear with you and you're wearing it when you're with the patients.
Okay. Oh, then also one question. It's off the record. It's concerning this